Thanks, Brendan. It's good to be back. Thanks for tolerating me a second time. The Sam Hughes lecture is also titled, when it's given at the annual meeting of the Society of Obstetric Anesthesia and Perinatology, the Ostheimer Lecture. The board of directors of SOAP selects somebody to review the literature for an entire year, and I was selected for the year of 2014, subsequently presenting the papers in 2015. I have nothing to disclose, but I do want to say that the first time that I watched an Ostheimer lecture at the SOAP annual meeting, I didn't like it at all. It was fast, it was dense, it was overwhelming, kind of like taking a sip of water out of a fire hose. And then Bob Geiser once told me, he said, no, that's not what it is. It's a bedtime story. It takes you and it reminds you of all the other the papers that you've seen throughout the year, and actually that we've seen throughout this meeting, and reviews them as concise as possible, giving you sort of a 1-hour nugget of an overview of a year in the literature in the field of OB anesthesia. So as we do that, I invite you to sit back. We have the syllabi that's going to be published in ANA here next month, as well as I can send anybody the syllabus that would like it, because as each paper is presented, the subject will be at the top, the annotated references will be at the bottom, and that syllabus number that has the 200 articles that I subsequently wrote about in the syllabus, that number of each paper is up into that right-hand corner. And finally, there'll be some papers or some topics that we review with multiple papers, and all those references will be listed. So overall, over 2,000 papers were read by myself and some of my colleagues that were helping me. The syllabus was over 200 articles, or 200 articles, and we will review today about 60 of them. So be ready. We'll begin in labor. We won't do very well because we'll head on back for a cesarean delivery. We'll develop a number of coexisting diseases. We'll get sick and die. We're going to start in labor. We're going to talk a little bit about labor pain and some psychological aspects of it. Labor epidurals in the second stage of labor. Epidurals and perineal injury. A little bit about epidural fever again. Pharmacology of labor analgesia. So Dr. Carvalho, who you've already spoke, published a nice article, which is worse, greater pain for a shorter duration or lesser pain for a longer duration, and 40 women scheduled for induction were surveyed regarding, asking questions in a binary fashion. Pain, would you prefer pain for 2 for 9 hours, or pain of 6 for 3 hours? And overall, both before and after their labor experience, women preferred lesser pain for a greater duration than greater pain for a lesser duration. So even if we find that epidurals do in fact prolong labor more than we thought, and they may not completely eliminate but instead just mitigate pain, women still would prefer that lesser pain over a longer duration. Does psychology predict labor pain? Well, we all see women cope with labor in so many different ways. And Dr. Carvalho also published this paper in which he used the Eysenck personality test to look at various different psychiatric results and relate those to analgesic outcomes. So women that on the Eysenck personality test tended to have a lying trait had a shorter time to request analgesia. Those with anxiety or high extroversion scores or psychoticism had a greater labor pain over time area under the curve. Women that had fear of pain scores that tended to be higher required greater epidural local anesthetic, and those that had pain catastrophizing at greater local anesthetics, and fear of pain scores lower labor satisfaction. This is an interesting question. Do epidurals prevent postpartum depression? And this prospective, non-randomized Chinese study looked at 214 women, half of which requested and received labor analgesia, the other half of which got no labor analgesia whatsoever. These women were then given the Edinburgh Postnatal Depression Scale at 3 days and at 6 weeks, and those with an epidural were far less likely to be depressed with an odds ratio of 0.3. Really interesting. Well, the media caught on to this with titles like this: Epidurals during childbirth can cut postpartum depression risks. Well, we know we're not there yet. However, it's very intriguing. And there was a nice editorial that accompanied this paper which discussed perhaps it has something to do with the pain experience of a woman not having the severe pain, kind of then subsequently starting her postpartum period off on the right foot. But the other question that was raised, perhaps it has something to do with the women who felt empowered enough to request an epidural that makes them less likely to go on to develop postpartum depression. So the question's still out. It's going to be very difficult to continue to study this. However, I think it's a very important question to study. We're going to move on and talk a little bit about labor epidurals in the second stage of labor. Does epidural analgesia lead to longer second stages? And if so, how much? Do more epidurals lead to more operative vaginal deliveries across a population? And a question of, do epidurals prevent perineal injury? Well, this here came right here out of UCSF. It was arguably one of the most controversial articles of 2014. And these authors took 42,000 vaginal deliveries that occurred here between 1976 and 2008. And they specifically, besides reporting the mean and the median percentile of length of second stage, they also reported the 95th percentile of the length of second stage. And look at these numbers. Among nulliparous women that had no epidural, the 95th percentile for the length of second stage was 197 minutes. Amongst nulliparous women with an epidural, that length of second stage was 336 minutes for a difference of 2 hours. And among multiparous women, that difference was 3 hours. Unbelievable. However, there are problems with this study. And this study, and nor do the authors claim, should not necessarily lead one to say that epidurals cause this prolonged length of second stage. Number one, any woman that began her 3 hours of second stage labor without an epidural is darn well going to have one by the end, right? And if this is retrospective, so absolutely. The other problem is that this was done over such a long period of time, 1976 to 2008. I was born in 1975, since I'm bringing up my age one more time up here. And that 1976, back then, they did a whole different type of labor analgesia as far as epidurals, much denser than we do currently. And these types of labor analgesia weren't reported. Finally, over this time period, forceps and vacuum delivery have become much and much less common, allowing second stage length to lengthen, while epidural use has increased. So, as a result, I would say that we definitely cannot cause conclusions. But the authors didn't say that it was causation. And instead, statements like this, because of this and many other studies from the SMFM and ACOG, published evidence now shows that labor actually progresses slower than we thought in the past. Many women might just need a little more time to labor and deliver vaginally instead of moving to cesarean delivery, a pattern that we've seen discussed elsewhere at this meeting. Let's move on and talk about whether increasing epidural use increases operative vaginal delivery, so increases forceps and vacuums. This perinatal registry of the Netherlands collected data between 2000 and 2009, and amongst nulliparous women during that time period, epidural use increased by 284%. And amongst multiparous women, it increased by 283%. During that same time period, though, instrumented vaginal delivery went down. Cesarean delivery went up slightly. So the authors concluded that if it were an important causal element in operative vaginal delivery, with such a large increase in epidural use, you would not be able to see that decline in instrumented vaginal delivery. But we know retrospective studies cannot necessarily lead us to definite conclusions. However, I think it does add to our knowledge in that area. As far as perineal injury, where do epidurals fit in? This study of 61,000 vaginal deliveries in an Israeli hospital looked at their deliveries between 2006 and 2011, 31,000 women delivering, half of which requested and received epidural analgesia. On univariate analysis, epidurals were associated with perineal injury. But that's not surprising at all. On multivariate analysis, however, epidurals were not associated with perineal injury, and you can see an odds ratio here of 0.95 with a confidence interval that crosses 1. So the things that were associated with perineal injury were instrumented vaginal delivery and prolonged second stage. One of the things that I think is interesting here is how much this odds ratio went down between the two, from here to here, once you started adding other elements in, things like fetal head circumference, maternal BMI, baby size, so on and so forth. This led the authors to conclude that perhaps the same things that lead a woman to request a labor epidural are the same things that result in perineal injury. Well, we could have told them that, right? But this is even more compelling as to the epidural's effects, because this study implies a protective mechanism of epidurals in the second stage. And this is the Danish Medical Birth Registry taking data between 2000 and 2010. And they entitled perineal injury with this fine acronym here, Obstetric Anal Sphincter Injuries, or OASIS. I want you to think about that for a minute. And the more you think about it, the more disturbing it becomes. So they looked at 215,000 primiparous vaginal deliveries. And when on univariate analysis, again, it looked like there was an association with an odds ratio greater than 1 and a confidence interval that did not cross 1 of epidurals and OASIS. On multivariate analysis, just by adding birth weight and vacuum in, suddenly the odds ratio was less than 1, implying protection. And on full multivariate analysis, adding age and BMI, fetal head circumference, the gestational age of the baby, the use of episiotomy, induction of labor, oxytocin use, shoulder dystocia, suddenly it became much more protective with an odds ratio of 0.84. And look at that confidence interval, all the way up as low as 0.88, which is significant. And as a result, this, amongst other studies, lead obstetricians to believe that epidurals actually have a role in preventing perineal injury. And the thought is that mechanistically, an epidural allows a woman to push with more control at the end. Instead of blowing that baby out, laying open that perineum, they can control that push, allowing stretching of the tissues. We talked about epidural fever yesterday. We'll talk about it again. Can antibiotics prevent it? The answer is no. This study, published in 2014, looked at randomizing women to either cefotaxime or placebo at the cefoxitin, or placebo at the time of the epidural, and epidurals did not decrease the incidence of fever or membrane inflammation. However, as with previous studies, placental inflammation, so that non-infectious chorioamnionitis, was associated with fever. So again, another study that shows us that it's inflammation and not infection leading us to that epidural fever. We're going to move now to pharmacology of labor analgesia, talk a little bit about how local anesthetics and opioids work in the CSE, in this intrathecal space, and a little bit about fetal heart rate changes after CSE. So this study took 300 nulliparous women and gave them fentanyl and or bupivacaine in the intrathecal portion of their CSE. They were randomized to one of 30 combinations. Some women got all bupivacaine, some women got all fentanyl, but most women got a combination somewhere in between. And what they subsequently did is calculate the decrease in pain scores both at 15 minutes and 30 minutes. And what they found was that there was lesser pain when you used both drugs together than if you used one drug alone, as predicted by a formula that looked at additivity. This implied synergy of the two drugs. This was true at both 15 minutes and at 30 minutes. And therefore, if you want more bang from your buck, as far as your intrathecal dosing, it looks like you should combine the two instead of using just one or the other. But those fetal heart rate changes are the things that we talked about earlier today regarding combined spinal epidurals. This study specifically looked at those fetal heart rate changes, 115 laboring women randomized to CSE that was initiated with this dose here you see of intrathecal bupivacaine or an epidural. There was no difference in fetal heart rate abnormalities between those two groups, the CSE or the epidural groups. However, both groups had increase in fetal heart rate abnormalities after the onset of analgesia when you compared the 30 minutes prior to the initiation of analgesia to the 60 minutes after the initiation of analgesia. The thing I want to point out, however, is kind of what we talked about this morning, and that is that very low dose of intrathecal opioid. So other studies have shown that a nice effective dose of intrathecal opioid is about 15 mics, and these authors used a very low dose of intrathecal morphine, 5 mics. This very well may have biased this study to show no difference between the two. We're going to move now on to cesarean delivery. We're going to talk about preventing spinal hypotension, anesthetic and analgesia requirements during cesarean, intraoperative awareness, oxytocin, post-cesarean analgesia, and general anesthesia in the fetal brain. All things we've talked about already at this meeting. This one, however, I don't think we have. And this is a little bit, we've talked about fluid bolus, but I want to introduce you to a concept that I learned a little bit about in 2014. You know what that is right there? That's the glycocalyx. I knew nothing about this, but it is an area of significant endothelial research right now. It's sort of this hairy substance that lies on the inside of the endothelial cells, and by being there protects the endothelial cells and allows them to function normally, allows nitric oxide synthase to function normally, allows them to not develop vasoplegia, and also allows them to appropriately not translocate fluid across the endothelium. Well, these authors looked at 30 women that received a 750 ml bolus of warm lactated ringers prior to C-section. Essentially, other research has found that if you wash off the glycocalyx, you can find those biomarkers actually in the plasma. And as far as you find more biomarkers in the plasma, endothelial dysfunction increases. This has especially been true in various disease states. So these authors looked at these biomarkers, heparin sulfate and syndecan-1, and what they found was that after this bolus, these biomarkers increased. So we disrupt the glycocalyx when we give that big fluid bolus. I think this begs the question of what could be next. Well, as far as cesarean delivery anesthesia, we've decreased our fluid boluses and amount of fluids in lots of other types of surgeries, colorectal surgeries, liver surgeries, and so on. And I wonder if we're going to find improved outcomes over the next decade of research in OB anesthesia with lesser fluids. Perhaps we're shooting ourselves in the foot by giving that liter co-load as we go, especially with phenylephrine infusions that can help us with hypotension. We're not there yet, but I do wonder. Speaking of prophylactic phenylephrine infusions, how well did they work? The answer is really well. This systematic review looked at 21 randomized controlled trials, and all these randomized controlled trials had the primary outcome of evaluating the efficacy of prophylactic phenylephrine infusions to prevent systolic blood pressures dropping less than 80% of baseline. And phenylephrine's relative risk for hypotension in comparison to a placebo was significant, 0.36. It was a little less significant than ephedrine, but still far better, a little less significant than a combination of both phenylephrine and ephedrine, but still far better. So it is the best drug that we have right now to prevent spinal hypotension. But how should we give it? Should we give it in a prophylactic infusion, a prophylactic bolus, or rescue boluses? These authors looked specifically at comparing a phenylephrine infusion to rescue boluses. And it was a randomized controlled trial of 80 women with a primary outcome of the number of rescue boluses. And of course, what they found is that in the infusion group, in comparison to the rescue bolus group, the infusion group got less rescue boluses. Not surprising. However, what was more interesting was their secondary outcomes. And what they found was, amongst hypotension, the phenylephrine bolus group, 90% of them became hypotensive, whereas the phenylephrine infusion prophylactic group, only 20%, quite significant. Nausea and vomiting was far less in the phenylephrine infusion group. But look at this, hypertension was greater with 15%. I'm sorry, this is supposed to be 0.026 here. So one of the things that I think is important here is that there is a patient population, such as our severe preeclamptics, that we need to be very careful with hypertension. And the other thing is everybody's patient population is different. So Warwick Non-Key subsequently published this editorial that accompanied this article. And he writes, "One shoe will never fit all. Because practices, patients, clinical scenarios, and providers are all different, anesthesia providers should be able to develop a phenylephrine regimen based on their local experience that provides an acceptable balance between the elimination of maternal symptoms and the risks of hypertension and bradycardia." Let's talk a little bit more about progesterone and its effects on the anesthesia and analgesia requirements. I think this is a fascinating study. These authors looked at elective cesarean deliveries, all greater than 36 weeks gestation, all receiving general anesthesia with a very specific formula for their induction and their maintenance of anesthesia, which was titrated to a heart rate and a BIS number. What the authors found is that the concentration of sevoflurane in comparison to the serum progesterone of which the woman presented with, there was a negative correlation. So as serum progesterone increased, the amount of sevoflurane the woman required decreased. Likewise, as serum progesterone increased, the amount of post-operative cesarean analgesia the woman required decreased. Therefore, there was a negative correlation. This implies that the greater progesterone that a woman arrives with for a cesarean delivery, the lesser her anesthesia and her analgesia requirements. I think this is interesting, not only from a predicting pain perspective, but also from a potential therapeutic perspective in the future. Well, we've talked about this a little bit, Dr. Geiser did, as far as intraoperative awareness, and the NAP5 came out in 2014. This was a prospective study involving 269 study coordinators in 329 UK hospitals, and even the coordinators and hospitals in Ireland as well, and they were to report accidental awareness under general anesthesia at their hospitals. The reports were reviewed by the NAP5 panel. The denominator was huge, 2.8 million general anesthetics that occurred during that time. And what they found was that the incidence of awareness under general anesthesia is about 1 in 19,000. However, obstetrics was the most overrepresented surgical specialty, with an incidence of 1 in every 670 cesarean deliveries under general anesthesia does it appear as if we have a case of true intraoperative awareness. The authors go on to say that there were many risk factors that were identified elsewhere throughout the NAP5 panel that they believe lead to people to be at increased risk for awareness. And these risk factors are often present in obstetrics. Things like rapid sequence induction, the omission of opioids at induction, difficult airway management, obesity, brief periods between induction and incision. Wow, it doesn't get any briefer than a general anesthetic for a C-section, right? High incidence of emergent surgery, and for them, high rates of off-hour surgery, which meant that they had higher rates of non-consultant anesthetist care. Well, could bispectral index monitoring prevent awareness? We talked about this study a little bit. You use the isolated forearm technique plus a BIS monitor to look at this. This is the isolated forearm technique. We described it earlier. Here's the headphones that every 20 seconds are saying open and close your hand. The IV for induction is on this arm. The blood pressure cuff is over here on this arm. This is insufflated. The IV induction has begun. This arm is isolated from the neuromuscular blocking agents, and the person is supposed to open and close their hands. I just want to point out that this person right here is not pregnant. So essentially, they followed a very specific formula. And as we saw, 41% of women at laryngoscopy opened and closed their hand. 46% at intubation, and 23% continued to follow commands at skin incision. This, of course, could not differentiate positive versus negative tests. This does not surprise us, does it? But no patients experienced recall. What does this tell us? It tells us we have so much to learn, and that our knowledge is just beginning regarding intraoperative awareness. All right, oxytocin infusion protocols. What came out with that in 2014? Well, Dr. Sen told us that we can try to decrease the amount of our oxytocin with various protocols, and this group at Northwestern showed that they could. And when they did undergo a protocol in which they started a pump that gave 18 units an hour instead of just doing this kind of roller bag type 10 units in 500 via an 18 gauge IV, they were able to decrease it by about 8.4 units. I should say milliunits. In difference, or international units, there was no difference between the groups in estimated blood loss, supplemental urinary tonics, or vasopressor use. So we were talking earlier, and the next thing is to try to figure out, are there benefits? Does that decrease in oxytocin? Can we really see a benefit for our patients by doing that? Pain after cesarean. There was one study that showed a lower incidence of chronic pain after cesarean delivery than what had previously been shown at both 6 months and 3 months. But this study also showed that acute postoperative pain is definitely related to chronic pain in cesarean delivery. Tap blocks after cesarean. This is interesting. One of the things that we were talking about a little bit earlier today about that risk of tap blocks, other studies in 2014 again showed that there was no benefit to adding tap blocks on top of intrathecal morphine. But tap blocks after cesarean, this PLOS One study right down here, this was a randomized controlled trial that was randomizing women to either get tap blocks or a suprafascial catheter that went into their wound, and it had to be stopped early because one of the women in the tap block group seized. Subsequently, there was also a report in RAPM of 2 patients that seized. There were some commonalities. Only one of these patients was at toxic dose, what we would traditionally consider toxic local anesthetic doses, and only just there. The rest were far below. All of the seizures occurred about 20 minutes after injection, implying systemic absorption and not necessarily intravascular injection. Other studies have shown these very high plasma volumes. There is a question whether there are women with cesarean deliveries, perhaps with aortic cable compression. They have additional blood flow that goes through the tap area. Maybe they're at even higher risk than other patients. It's a question I have. I'm also regional fellowship trained. When I do tap blocks, I don't do more than 0.25% bupivacaine, no more than 20 cc's on each side with 1 to 200,000 of epinephrine, and always under ultrasound guidance, being careful not to give an intraperitoneal or an intramuscular injection. All right, moving on to general anesthesia and the fetal and neonatal brain. What had been previously shown in the rodent brain was also shown in the non-human primate brain, in which the isofluron's apoptotic effects increased throughout the 3rd trimester, probably into the neonatal period, probably having something to do with effects on oligodendrocytes. That's when they begin to develop myelination potential. And so it's not, we actually get a worse effect as we approach of the isoflurane. There was also some great studies that looked at adding various other things to anesthetics to try to decrease their neuronal apoptotic effects in various animal models. So if you add hydrogen to sevoflurane in the fetal mouse model, or if you add carbon monoxide to isoflurane in the neonatal mouse brain, in the neonatal mouse, or dexmedetomidine to ketamine in a 2-month-old rat, all of these things looked as if they decreased neuronal apoptosis. I like these studies because they're already looking for solutions to a problem that's potentially there. And that's the benefit of us really going after this problem, looking for solutions. At the same time, we're looking at the mechanism and the epidemiology of it. Coexisting disease, we're going to talk a little bit about obstructive sleep apnea and opioid use in pregnancy. What's the impact of OSA on pregnancy? Well, this nationwide inpatient sample database that looked at deliveries admissions for delivery between 1998 and 2009 involved almost 56 million maternal hospital discharges. Looking at the ICD-9 diagnosis of OSA, found that there was an average annual increase by 24%, seeing increasing OSA diagnoses, whether this is because there's more women that have OSA or more women that are getting recognized and diagnosed with OSA that have always been there, we don't know. However, controlling for obesity and other confounders, there are a lot of problems with OSA. Starting at the bottom, cardiomyopathy, as far as once a woman has an OSA diagnosis in her chart, she has an odds ratio of 9.0 cardiomyopathy. CHF, odds ratio of 8.9. Pulmonary edema, eclampsia, pulmonary embolism, and preeclampsia. There's problems. OSA does cause other pregnancy problems, it looks like. Also, really compelling from our standpoint, women with OSA had a 5-fold increased odds of in-hospital mortality. Wow. Now, the article does not go in and describe these mortalities and how they occurred, but we do wonder, don't we, if it had something to do with hypoventilation or if it had something to do with these other disease states that we see OSA lends to. All right, we may be developing yet another tool up in OB anesthesia, lung ultrasound. And these authors looked at whether lung ultrasound can see pulmonary edema and predict hemodynamics in severe preeclamptics. They looked at pulmonary edema with these various different scores, looking for these various different patterns with lung ultrasound. And what was the most interesting was that they found that they could predict hemodynamics by transthoracic echo by doing lung ultrasound and calculating an echo comet score. I think this is interesting because I have done lung ultrasound before, and it's actually really simple as far as doing it. And for those preeclamptics where you're really trying to balance their fluid, and they can be very difficult to figure out how do I keep them intravascularly resuscitated and yet not fluid overloaded and developing more and more pulmonary edema, yet another tool to help us with fluid management. Opioid use in pregnancy. These authors did took the Medicaid analytic extract between 2000 and 2007, which encompassed over 1.1 million completed pregnancies, and found that almost 22% of women in pregnancy filled an opioid prescription. Wow. The most common cause, the most common reason was abdominal pain. 48% of them for abdominal pain. There were regional differences. The Northeast did the best, with only 9% of their patients getting an opioid during pregnancy. The South, guys, didn't do so well, 35%. And Utah, anybody here from Utah? 41.6% of women in Utah filled an opioid prescription. So from 2000 to 2007, the rates increased from 18% to 23%. So there was also significant increases. Well, is opioid use and abuse a problem in pregnancy? These authors did a nationwide inpatient sample study between 1998 and 2011, which again, 57 million delivery admissions. They found that during that time period, 98 to 2011, opioid use or dependent increased. And when they looked at the adjusted odds ratios for various outcomes amongst the patients that had opioid abuse or dependence listed in their charts, they had a 4.6 odds ratio of increased in-house mortality, cardiac arrest 3.6, IUGR, placental abruption, preterm labor, oligohydramnios, blood transfusions, and stillbirths were all increased amongst these patients. So it is a problem. We're going to move now on to talking a little bit about morbidity and mortality. We're going to talk about the SCORE project. We're going to speak a little bit about maternal cardiac arrest, postpartum hemorrhage, sepsis, maternal early morning hospital, and finally we're going to end talking a little bit about worldwide maternal mortality. So, the SCORE project. The SCORE project was performed in order to determine the incidence and risk factors that are associated with obstetric anesthesia complications. It stands for the Serious Complication Repository Project for Obstetric Anesthesia, and involved 30 institutions, probably many of yours, over 5 years. There were 257,000 obstetric anesthetics in the denominator, and in total they found that there were 157 total serious complications for a rate of about 1, or an incidence of about 1 in 2,000. Likewise, there was an 85 what were determined to be anesthesia-related complications for a rate of about 1 in 3,000. What were those outcomes? Well, the incidence of maternal death in that population was 1 in 10,000, cardiac arrest 1 in 7,000, serious neurologic injury 1 in 11,000, respiratory arrest in a labor room 1 in 8,000, failed intubation 1 in 500, high neuraxial block 1 in 4,000, an unrecognized spinal catheter that was dosed like an epidural 1 in 15,000. Speaking of cardiac arrest, what are the incidents and causes of maternal cardiac arrest? Our own Lawrence Sen, along with colleague Jill Meyer, published this incredible article in 2014 involving, again, 57 million deliveries between 1998 and 2011, and they looked at all the women that had arrests. There were 5,000 about cardiac arrests for an incidence of about 1 in 12,000. 60% of the women survived to discharge, which is very good for most out of OR cardiac arrests, although some of these may have definitely occurred in the OR. As far as lowest survival, aortic dissection and trauma. As far as the causes of arrest with the highest survival, those that really happened with us or under our care, anaphylaxis, magnesium toxicity, aspiration or anesthesia complications, those have the highest survival. The cause of cardiac arrest, 45% of the arrests were caused from hemorrhage, either that began in the postpartum or began in the antepartum. Heart failure, amniotic fluid embolism, sepsis, anesthesia complications, aspiration pneumonitis, venous thromboembolism, and eclampsia were the other causes that you can see there. I do want to point out aspiration pneumonitis. It was a cause of 7% of the cardiac arrests in this population. I also want to point out that the SCORE data had none. What was the difference between these 57 million women and the 257,000 women previous that were looked at with the SCORE project? Well, everybody that was submitting data into the SCORE project had to have an engaged obstetric anesthesiologist that wanted to be submitting that data. So some people say the SCORE project showing no aspiration means that we don't have to worry about aspiration at all. I would say no, the SCORE project shows us that we're doing something right, because women elsewhere that may not be under our care are still dying of aspiration pneumonitis. What were the medical conditions that women had that increased their likelihood of arresting in this population? Pulmonary hypertension, adjusted odds ratio of 13. Be very scared when they come into your labor and delivery unit. Malignancy, ischemic heart disease, liver disease, congenital heart disease, lupus, cardiac valvular disease. Do you see a pattern? Cardiac, 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 cardiac. You need to know how to take care of cardiac disease in pregnancy, because they are the women that are more likely to arrest when they come into your labor and delivery units. We talked about this already, the Society of Obstetric Anesthesia Perinatology consensus statement on the management of cardiac arrest. Subsequently, the AHA guidelines and circulation have already been published regarding this. This is a great read. If you are in charge of an OB anesthesia unit or you practice, you really need to read this article. It highlights great education strategies for your units, communication strategies, how to test your system, and all the point of care checklists you should have. Of course, previously, there was a thought that you should have these women flat on their back during an arrest, but this article talks about that left uterine displacement, which you stand on the side of the patient, actually extracting that uterus to the side. The other thing that's different about this and previous, there used to be some thoughts that you would change your hand position on the sternum during chest compressions. However, this, as well as the AHA guidelines, say keep your hands in the same positions for chest compressions that you would do for a non-pregnant woman. All right, bundles, bundles, bundles. I know I'm sick of them, but the question is, do they work? Can bundled practice changes actually prevent maternal mortality? This study was done by the Hospital Corporation of America, and between 2000 and 2006, they actually had a study that described their baseline maternal mortality. Subsequently, in 2006, they intervened with 3 protocols, and this publication actually reported their number of deaths between arrests between 2007 and 2012. 81 deaths for a rate of 1 in 15,000. They subsequently, but in that 2006 period, intervened with 3 bundles. One was universal sequential compression devices placed before, run during, and continued after cesarean until the woman ambulates. Hypertensive crisis and pulmonary edema protocol, teaching nurses how to quickly recognize pulmonary edema and how to alert physicians if there's increasing oxygen requirements. And a hypertensive crisis protocol in which women or nurses had a standing order for antihypertensives for women that came in severely hypertensive. They didn't have to wait for that physician order. And then finally, a PPH protocol. Many of us have these that allow us to get the team as well as the equipment and the blood quickly in order to treat postpartum hemorrhage. What they found was that the rate of death from PE decreased after the implementation of this bundle. The rate of death from preeclampsia and eclampsia decreased with the implementation of this bundle. But the rate of death from hemorrhage did not decrease, and in fact, there was a trend with a p-value of 0.07, so just a trend towards an increase in deaths in postpartum hemorrhage. So that bundle, although still important, did not necessarily affect mortality. Let's talk a little bit about postpartum hemorrhage. There was the closed claims database study that looked at hemorrhage. We've seen this study presented elsewhere throughout our time together here this weekend. And it involved 3,000 claims of hemorrhage in which anesthesiologists were successfully sued. 30% of all hemorrhage claims in anesthesia are against obstetric anesthesiologists. And there's one thing in common with all these claims, minus maybe one or two of them, and that was lack of timely diagnosis of the postpartum hemorrhage, okay? So in other words, these women hemorrhage were called in late and then were held liable for failure to rescue. So we need to do a better job, and we need to do a better job not just in our resuscitation and all the things that Alex talked to us about how to treat postpartum hemorrhage. We need to do a better job of recognizing postpartum hemorrhage up front. And what are some ways that we could do that? Well, maybe we could put some sniffers in our computer systems. I don't know about you, but we're moving to a new computer system here, and since I'm on camera, I won't make any comments. Obstetric shock index is one thing perhaps we could implement into our electronic systems, in which it specifically looks for a particular trend in numbers that would subsequently alert physicians to come by and check a patient for potential hemorrhage. An a shock index is a number that's been used in trauma and non-trauma bleeding to look for people that could be bleeding and to potentially quantify that bleeding. These authors looked at women retrospectively that had previously experienced a massive PPH, so greater than 30% loss of their blood volume. And what they found retrospectively is that within 10 minutes of when the providers believed that postpartum hemorrhage initiated, there was a difference between a control group that was not hemorrhaging and the PPH group in the obstetric shock index. So you can think of this shock index kind of as your heart rate goes up to 100 and your systolic blood pressure goes down to 100, you start reaching 1. And what I tell my residents about this is that if you start seeing that in your obstetric shock index is trending upward, and maybe even you could think of it as greater than 1, think about postpartum hemorrhage. I think it'd be important to implement this as well as perhaps other techniques to perhaps start looking for those women that could be developing postpartum hemorrhage and recognizing them earlier. Well, what about tranexamic acid? Whew, that's complicated, right? As Alex talked about earlier, well, this systematic review, which he talked about, involved 7 trials, and it didn't clarify a thing for us, except essentially they found that the blood transfusion decreased amongst women, low-risk women that received tranexamic acid for prophylaxis for cesarean delivery. And that risk ratio of hemorrhage with the tranexamic acid is profoundly low, but I want to show you how big that confidence interval is. Now, the problem is that there were 2 trials that had extremely high, like 10% transfusion rates. It was unbelievably high. So the authors repeated their analysis, eliminating the 2 trials with these extremely high transfusion rates, and what they found was that the confidence interval now crossed 1, implying that they cannot yet tell. Alex subsequently told me right before this that this study itself has been highly criticized, actually, for ranking the quality of its studies within it higher than what others would rank them. So we have still more to learn. The jury's still out, and we await the results of the woman trial, which again Dr. Butwick talked to you about. Can we conserve blood in stable anemic postpartum hemorrhage? How low can we go? So this randomized controlled trial is non-blinded. It was done in a non-inferiority design in which they looked at women 12 to 24 hours after their postpartum hemorrhage. They said that they could enroll women at this point between a hemoglobin of 4.8 and 7.9 as long as they were stable, not bleeding anymore, and again, 12 or 24 hours out of that hemorrhage. The women were randomized to an intervention arm in which they would be transfused up to a hemoglobin of 8-9, or a non-intervention arm in which they were transfused only if they developed what they called severe symptoms. Their primary outcome was physical fatigue at 3 days on an 18-point fatigue scale. The intervention group got a total of 2 units of RBCs with an interquartile range of 2 to 2 with a discharge hemoglobin of 9. The non-intervention group got no blood, typically with the discharge hemoglobin of 7.4. I do want to show you that they never got down to this 4.8. Their lowest hemoglobin in that non-intervention group was 6.8. Because remember, these patients had to be asymptomatic. Non-inferiority was not demonstrated. There was a just under 3-point difference in fatigue on that 18-point fatigue scale. But compellingly, there was no difference in secondary outcome, no difference in breastfeeding, infection, or thrombosis rates, implying that it's very safe to allow patients to go ahead and be discharged with hemoglobins between 6.8 and 7.7 if they're asymptomatic. Well, the United Kingdom has mandatory maternal death reporting, and they published their triennial report in 2014. They found that between 2009 and 2012, they decreased their overall deaths with 10 deaths per 100,000 maternities compared to their prior triennium, which had 11 per 100,000 maternities. There were some patterns. 2/3 of women died from indirect causes, meaning not obstetric causes, meaning not obstetric hemorrhage or other things, or preeclampsia or other things related to pregnancy. And 3/4 of the women who died had coexisting medical conditions. So women that are chronically sick, getting pregnant, and getting sicker and dying in pregnancy. Therefore, the authors really emphasized the importance of managing pre-existing medical conditions, and finally, the ability to provide critical care support within your OB unit, or the ability to provide OB care up in your critical care unit. Wow, does this involve us or what? I mean, we can really help out with these lung diseases and these cardiac diseases and so on. It's kind of like when you stand in your rounds and one of the obstetric residents says, yeah, she's got some cardiac disease, but her ejection fraction is just fine. Say, what is it? 76%. Say, wow, well, what cardiac disease does she have? And he says, well, something like HOCM or something like that. It's no big deal, right? I mean, we really can have a fund of knowledge that can help. We understand the physiology. Finally, as far as the maternal mortality goes, they want to continue the Think Sepsis campaign in the UK, although the number of deaths the number of deaths because of sepsis has declined in their reports. There are still many preventable deaths that occur as a result of sepsis. Why is sepsis so difficult for us in pregnancy? Well, these authors looked at tons of numbers from control groups throughout a gazillion studies, and essentially what they found was that the SIRS criteria overlap with healthy vital signs in pregnancy in the 2nd trimester, the 3rd trimester, and in the peripartum. Well, no wonder it's so hard. And that was true for all SIRS criteria except for temperature. All the other ones overlapped. So is there a new tool for us to detect sepsis in pregnancy that we could again utilize to help recognize these patients? Well, these authors came up with what was called a sepsis and obstetrics score, and which is a retrospective score looking at 850 pregnant and postpartum women. They gave them 1 to 4 points for various vital signs or lab scores that were, as far as how far those vital signs or lab scores were away from normal. They got additional points. And they found a very nice sensitivity and specificity of this score. This was all retrospective with their primary outcome looking for ICU admission. However, in prospective validation is required, but it's compelling research. Things that can help us create sort of computer systems to recognize patients that are bleeding, to recognize patients with sepsis, and to perhaps promote us to further evaluate with further tests and studies. What is the cause of peripartum sepsis? Well, this study came out of the UK looking at 780,000 maternities in which there were 365 cases of severe sepsis for an incidence of about 4.7 cases of severe sepsis in 10,000 maternities, so it's rare. 1.4% of those women, or 5 of them, died. 20% developed septic shock. In the antepartum, the cause of sepsis was by and large E. coli. These are the cases in which they were able to identify a bug. In the postpartum, by and large, the bug was E. coli. However, there was another player in the postpartum that we all need to be aware of, and that's group A strep. In the group A strep group, it comprised 13% of all the identifiable causes of sepsis. 50% of women went from their first sign of SIRS, or sepsis, to fulminant septic shock in less than 2 hours. That group A strep moves very, very quickly. So be careful of that postpartum sepsis. The National Partnership for Maternal Safety was developed in 2012, and their goal is to reduce maternal death and morbidity by 50% over 5 years. This organization involves many organizations involved in women's health, including SOAP. They really want everybody to come out with these core safety bundles, much like the safety bundles we talked about in that Hospital Associations of America study. And these are obstetric hemorrhage bundles, severe hypertension in pregnancy, and venous thromboembolism prevention. They want these to be implemented in every birth facility in the next 3 years. Well, one of the things they looked at is the implementation of an early warning system. And I just want to let all of us know that the UK is way ahead of us here. This survey that they rolled out, that they did in 2012, showed that 100% of the UK hospitals, because it's part of their NHS system, use what's called a modified early obstetric warning system. Many of you have probably heard of these. They use a multivariable warning system, much like this one, in which they'll say one vital sign or finding in the red indicates a mandatory call to a physician, or 2 in the yellow, and subsequently the consultant physician needs to come by, or the resident physician needs to come by, see that patient and evaluate them for whatever problem they may have. So it's a mandatory early warning, or a maternal early warning system called MEOWS. The National Partnership for Maternal Safety, they would like to roll out in the United States the maternal early warning criteria. Now this is a single variable warning system which could be rolled out in your unit, which essentially has these vital signs and symptoms. And if these patients show the vital signs or symptoms, the nurse is to call and alert a physician. Most likely your obstetricians, but you could put particular vital signs for your team to be alerted for. These are things like a heart rate less than 50 or greater than 120, and you see the systolic blood pressure there. What I really liked was that oxygen saturation on room air of 95%. You should not have nursing orders in your system that say keep oxygen greater than 92% with nasal cannula oxygen for postpartum women. You need to make sure that's out of there. Instead, they should say for women that have oxygen saturations less than 95%, alert your OB anesthesia team and alert your obstetricians. They can go ahead and start giving the oxygen, but you need to be alerted. All right. Well, this is where we end. The World Health Organization had the Millennial Development Goal of reducing maternal mortality by 3/4 by 2015. There were multiple themes throughout the literature in 2014, including near miss and maternal death reviews, evidence-based guidelines adherence, postpartum hemorrhage reduction and treatment protocols, preventing abortion and especially unsafe abortion throughout the world. In spite of this, in 2014, there were 289,000 maternal mortalities. There were 2.6 million stillborn babies, and there were 3.0 million babies dying within 1 month of birth throughout the world. We have a lot of work to do. Thank you very much. I'd like to thank my 2 colleagues who helped review articles. That was Hans Swigum and Becky Johnson. It was a lot of work, and also the Society of Obstetric Anesthesia Perinatology for allowing me to give this lecture and to have this honor. There were many, many people that helped me with both the syllabus development as well as developing this lecture. Thank you to the Shnider organizing committee. Finally, I'd like to thank my family. I was telling others I work 5 clinical days a week, so a lot of that work got done on weekends and evenings. My daughter's in the back, and here she is right now. She's an incredible little hockey player. Thank you very much.